Good afternoon. I'm the Reverend Charisma Jean Marie, and I serve as the Director for Racial Justice Ministries at Scarritt Bennett Center. And I'm excited to bring you another live stream conversation with one of our beloved partners, Meharry Medical College. We're excited about this conversation this afternoon because as a Black woman, this is personal. I know what it's like to go to the doctor's office and not feel like I'm being heard by my doctors. I know what it's like to shop for doctors who I feel is in the best interest of serving me and my well-being as a Black woman. Because the reality is racism is insidious and it is everywhere. So systemic racism, even in the medical field, is a reality for many Black women, specifically women who are given the gift of bearing children. Black women are the first and only group that dies disproportionately in childbirth. That speaks volumes to the ways in which Black women are regarded in the medical field. So I'm grateful for our partners who are able to come and share great information specifically to Black women and how to care for themselves, but also how to advocate for themselves when they go to the doctors, and also the resources that are available for us in our communities. So again, I thank you so much for tuning in, participating in this conversation. And as always, you are always welcome to share your comments and also your questions. Your questions will be very important this afternoon because you have healthcare professionals who's willing to engage you this afternoon with your questions. So all of your questions and comments, we invite them in our live stream post this afternoon. And we invite you to share this, to host a watch party and share this in your own post so that other Black women can see this, that they too might get the information they need. So again, thank you for joining us. And I want to say thank you to all of the panelists this afternoon for coming to be with us this afternoon to share your expertise. Angela, I turn it over to you.
Thank you so much. Before I start, I want to give a special thank you to Scarritt Bennett Center for this partnership and for this opportunity to talk about this topic on this platform. As mentioned, I am Angela Good, Program Manager for the Nashville Strong Babies Program at Meharry Medical College. The Nashville Strong Babies Program is a Herschel-funded grant award in collaboration with the Metro Public Health Department in partnership with the Department of OBGYN and the Department of Pediatrics here at Meharry. The Nashville Strong Babies Program efforts are focused on several primary zip codes within the Metro Nashville area who have the highest rate in maternal and infant mortality in the county. Our services under Nashville Strong Babies include OB care, OB group education, pediatric care, group pediatric education, behavioral health services, health coaching, as well as making available to those who need extended clinical hours, weekend appointments, and offering in-home visits and exams. Participants work with case managers through the health department and SB who helps identify barriers that would prevent a healthy pregnancy and baby. If you're interested in learning more about Nashville Strong Babies, feel free to contact me, 615-327-6788, or visit NashvilleStrongBabies.org. We have the extreme pleasure of having some dynamic women to speak on maternal health and maternal mortality. The first speaker that we have up is our very own nurse, Erin Van, and a little bit about her. Ms. Erin Van is a board-certified women's health nurse practitioner here at Meharry Clinic. Bam grew up in Montreal, California, and attended the University of California, Los Angeles. She later attended Vanderbilt University in Nashville, where she received her master's degree in nursing in 2016. Van Van received accreditation as the NAMS Certified Menopause Practitioner in 2018. She has special interest in hormone replacement therapy, infertility, and functional medicine. She enjoys traveling, skincare, and listening to podcasts. She and her husband, Vincent, has one daughter, Lily. I turn it over to you.
All right, thank you, Angela. I'm really excited to be here to talk with everyone. So I just wanted to kind of first start out with the definition of what maternal death is. Definition of maternal death is the death of a woman while pregnant or within 42 days of termination of a pregnancy, and that is irrespective of the duration or site of the pregnancy, and it is not caused by any accidental or incidental causes. So things like car accidents would not factor into maternal death. When it comes to Black women and maternal death, Black women in the United States are definitely at a significantly higher risk than white women and other racial minorities. Black women are also have a higher risk of death from things like pulmonary embolism, hypertensive disorders, and cardiomyopathy. And then also just some statistics on race and ethnicity when it comes to maternal mortality. Like I said, there's a significant disparity between Black women compared with white women, and the disparity does not seem to be getting better. Women who are 30 years and over were 4 to 5 times greater risk of having maternal mortality compared to white women. And even among women who were college educated, the PRMR, which is the pregnancy-related mortality ratio for Black women, was 5 times higher than that of white women. So that was even, again, women who are college educated or higher. So this represents one of the largest perinatal health disparities in the United States. So I think it's really pertinent that we're talking about it today. Few other things to just give a little summary. Black women aged 25 and older have a 4-fold greater risk of dying for pregnancy than white women, and the excess risk of death is highest among Black women aged 40 and older. So age definitely plays a role as well when it comes to Black maternal mortality. A few other things. So obesity is rampant in our population. Black women of all ages are more likely to be obese than white women. And obesity is the onset of it in young adulthood is faster in Black women and Hispanic women than in white women. There are a lot of conditions associated with obesity. It increases the risk for venous thromboembolism related maternal death and deaths associated with cesarean delivery, preeclampsia, and cardiovascular disease. So just to bring up a graphic here that I feel like really helps visualize maternal mortality in Black women. Let me pull that up real quick. It's this one right here. Let me make it a little bigger first before I pull it up. So, I don't know. Can you guys see that? Cool, good. So yeah, so I just thought this is a nice little graphic to show the US maternal death rates per 100,000 live births. You can see that Black women are significantly higher than women of other races, and then white women being the lowest. So let me just stop that. I'm not sure how to exit out of this. Oh wait, hold on, there we go. Okay, so that just gives a little good graphic representation. A few things I did want to just touch on when it comes to conditions that would contribute to the maternal death rate. One of those things being preterm birth, which that kind of more relates to infant death rate, but it's still very pertinent for Black women. So preterm birth, it's 52% higher in Black women than it is in white women. And it's one reason that infant mortality is high amongst women of color. And amongst infants, 2/3 of infant mortality occurs in preterm infants. One contributing factor of preterm birth which has been shown in some studies, is vitamin D deficiency. It's something that I'm really passionate about. I test all of my pregnant women for vitamin D, especially the population that I see. I see a lot of women of color, a lot of Hispanic, a lot of Black women. Vitamin D deficiency is more prominent in women of color because vitamin D, 90% of someone's vitamin D status comes from the sun. And the more melanin you have in your skin, the less vitamin D you're able to absorb from the sun. There was a study in 2017 that looked at vitamin D status in relation to preterm birth in over 1,000 women who received vitamin D 5,000 IUs a day, which is about over 8 times the RDA limit of vitamin D. And most prenatals, just so people are aware, most prenatals have about 400 IUs. A good prenatal will have about maybe 1,000 for a good one. But I would say that most prenatals have about 400 IUs and RDA 600 IUs. So these, in the study, they gave women 5,000 IUs. They tested their vitamin D status when they came into care, and then they gave them free vitamin D supplements, and they tested them later on in the pregnancy. And then they looked at the outcomes for preterm birth. So I will just share this screen real quick so you can see the outcome. Let's see, pull it up real quick. So share screen. There we go. So, and you can see in the study, the results were pretty dramatic. They gave the vitamin D, you can see before and after giving women the vitamin D. So overall, amongst all races, after, if they had a follow-up test of greater than 40 nanograms per milliliter, they had a 60% lower rate of preterm birth. And then if you break it down by races, white women versus non-white women, those who did take vitamin D, amongst the non-white women had a 78% lower rate. So overall 60% amongst all races versus 78% with non-white women. And then you can see with white women, it did go lower, the preterm birth rate, but it wasn't as significant as it was for Black women. Let me stop that real quick. So I think vitamin D is critically important. It's a very simple, cheap, effective intervention for women that has been shown to reduce preterm birth rates. It also there's studies showing that it could help with preeclampsia prevention, which is one of the major contributors of maternal mortality. So again, that's one thing I am very passionate about, and that definitely affects Black women much more than it does white women. Also, just talking about diet and preeclampsia. So preeclampsia, like I said before, women have a higher rate of death from hypertensive disorders, including preeclampsia in pregnancy, and there are some contributors to preeclampsia. One of those that they have shown that could potentially contribute is a higher carbohydrate diet. So carbohydrates in general, we get way too many carbohydrates as a country from just soda and bread and cereal, things that really don't have any nutritional density. So by increasing things like meat, vegetables, that can also help really overall contribute to reducing risk of obesity, reducing risk of preeclampsia, other things that are affecting maternal mortality. Low iron status, that is a problem that affects more Black women than it does white women. So in African-American women, the prevalence of anemia during pregnancy is 27% versus 7% in white women. Again, low iron has various effects during a pregnancy, but it also is a risk factor for preeclampsia, also a risk factor for preterm birth. So making sure that iron is within a good range for women and making sure that it's good before they even get pregnant is really important. Again, especially for Black women, they're way more likely to be anemic than white women. And like I already touched on, vitamin D, just the critical importance for overall health, for immunity, for bone health. And like I was saying before, preeclampsia, preterm birth, deficiency has been linked to low birth weight in infants and also gestational diabetes. So all these things are of critical importance. Other things, there was a study I was reading where women, actually Black doctors have reduced rates of infant mortality. So if you have a white doctor versus a Black doctor, your baby in this study was less likely to die if you're a Black patient and you had a Black doctor, which definitely we were talking as she was introducing this topic, we have a bias in this country, and just this institutional bias that really needs to be overcome. So, and also, like the speaker said at the beginning, having authority and having the ability to decide who your doctor is, I think is critically important. If you aren't happy with the care that you're receiving as a patient, you have every right to fire your doctor. And I tell my own patients that if you're not happy with your doctor, your provider, a nurse practitioner, physician's assistant, whoever your provider is, if you aren't happy with the care you're receiving, fire them because you're paying for your service. And if you're not happy, then you definitely deserve to go to someone who's treating you right and who is involved in your care and wants the best for you and is not, who's hearing you and listening to you and giving you options. And I think that's just so, so important. And again, I try to tell my patients that every day, that if you're not happy, then you can definitely see someone else. And if you're not being treated fairly, to shop around to find someone who is listening to you. So yeah, that pretty much sums up my discussion of this, but I'm happy to, and then after we get done with all the speakers, happy to address any questions that anyone has.
Thank you so much, Erin. That was a lot of good information. And I too read that article about how the mortality rate versus the race of your doctor. It was really interesting. Also, at this point, I want to remind our participants on Facebook Live to please be sure to write down your questions for our Q&A when we're done. Also, please share. You know, this is a lot of good information. We really need to get it out into our community. So please take a moment to share this live on your page. All right. Okay. So with that being said, our next speaker, we have Miss Tamara Corinne. She is with the March of Dimes, Director of Maternal Child Health in the government affairs at the March of Dimes. She has worked in public health, nonprofit arena for 20 years and has a passionate interest for issues and policies affecting the health of women and children. Tamara has been with the March of Dimes for 13 years in a variety of capacities, including a multi-state government affairs role that required navigating varying legislative structures and language barriers to yield successful passage of law. Tamara completed her undergraduate and graduate studies at the University of Tennessee in Knoxville. After holding certification as a certified health education specialist, Tamara was chosen due largely to her part in her policy successes to be part of the inaugural class Master Certified Health Education Specialist as designated by the National Commission of Health Education Credential Incorporated. Please, let's give a warm welcome to our next speaker, Ms. Tamara Curran. Thank you.
Good afternoon, everyone. Thank you, Angela, for your welcome. It's my pleasure to be here today as a part of this conversation and to represent March of Dimes. Of course, our mission is about fighting for the health of all moms and babies and believing that every baby deserves a healthy start. So the conversation so far has definitely been in alignment with our mission. Just a brief introduction to those who may not be familiar with the March of Dimes. We were founded in 1938 with an original mission to find a cure for polio. And our work led to the successful finding of the polio vaccine, widely distributed. And then our work moved into birth defects prevention and premature birth prevention. And so that's where I want to talk a little bit today about the infant side of things. Of course, Black mothers and maternal health is interconnected with the health of a baby. As Erin outlined in some of the information about the maternal side and then some of the pieces about the infant side, those outcomes for mom and baby are interconnected. Healthier moms lead to healthier babies. And so just wanted to talk a little bit about some of that impact of preterm birth, not only in the US, but specifically in Tennessee. And the March of Dimes launched a prematurity campaign in 2001. And the goal of that campaign is simply to reduce preterm birth in the nation and individual states to no more than 8.1% of babies born every year being born at preterm. And so we know we have a ways to go, especially here in Tennessee, where our preterm birth rate is at 11.1%. And that really equates to around 8,900 babies born early each year. And so just to talk a little bit more about that today. But if babies are in a position to be born at full term or as close to that 40-week time frame as possible, then we know that some of the unfortunate outcomes for babies are less likely. So just a little background for comparison on the US versus Tennessee. So here in the United States, about 380,000 babies are born preterm, so less than 37 weeks of the 40-week pregnancy. About 380,000 babies born at less than 37 weeks each year. And so after nearly 10 years of a decline, the past several years, we've seen a steady increase in those preterm birth rates. In Tennessee, in 2018, there were about 8,900 babies born preterm, as I mentioned, and that equates to about 11.1% of our babies being born preterm, and 1 in 9 babies is another way to look at that. So for every 9 babies born, 1 of those babies is preterm here in Tennessee. The preterm birth rate of 11.1% earns us a grade of D on the March of Dimes report card for the number of babies born too soon. And so we know, I've used this analogy oftentimes, and I guess it's especially relevant with where we are in COVID-19 right now. But with virtual schooling and that kind of thing, if children are bringing home Ds or making Ds in virtual school, that would, not be a pleasant conversation in a household. And so when we look at the number of babies born early and receiving a grade of D on the March of Dimes report card, we know that that's not necessarily good news. But I will say that there has been progress. Dr. Ladson, I know you'll remember there have been several years when we received a failing grade. So we have seen some improvements, but I think our prematurity campaign gives us a benchmark of where we need to go. So from 11.1% to trying to get closer to steadily that 8.1% goal of the prematurity campaign. The reason that's important, no surprise to anyone, premature babies have more health problems and need to stay in the hospital longer than babies who are born full term. Some of the babies also face long-term health effects, problems with the brain, lungs, hearing, or vision, which are some of those areas that are last to develop in a pregnancy. So that's important, that we want to make sure babies have as long as they can, close to that 40 weeks as possible. We also know that babies who are born early are also likely to be small or at low birth weight. So 5.5 pounds or smaller is typical for a premature baby. And then those babies are at increased risk for infant mortality. So babies who are born preterm and at low birth weight are the leading cause of death within the first month of life. And then of course, causes such as birth defects and so on are the risk within that full year of life. To date, and when thinking about the prematurity campaign, in Tennessee, we have 95 counties. And only 4 counties have to date met that 8.1% goal. So again, we have a long way to go. We also see in different counties or cities here in the state, even though our state grade is a D, there are some varying grades from C to F in cities here in the state of Tennessee. So again, that gives us, the report card gives us some benchmarks about where work might be needed somewhat more to make a difference in that overall goal. On that report card, and if anyone is listening and wants to look along while we're chatting, marchofdimes.org/report card is where you can click on the map and find the Tennessee report card. But on that report card, it also highlights some racial and ethnic disparities where women of color, no surprise, as Erin mentioned, are at more risk to have a preterm baby. And then we also see some disparities in terms of geographics. As I mentioned, just, certain parts of the state, there may be more likelihood for a preterm birth based on the geographic as well. The disparity in terms of African-American women specifically, they're 45% higher possibility of preterm birth among African-American women. And so that's a significant difference as compared to other racial and ethnic groups. In terms of risk factors, who's more at risk, what things make you more at risk for preterm birth? That could include things like a prior history of a preterm birth. So that's an important area to address when we get to a place where we're talking about solutions. Women who smoke, women who have inadequate prenatal care. We know things like education level, poverty, job status, and stress can also contribute to those outcomes that we don't prefer to see. And then also with preterm birth, it's a costly condition. And so fees and costs associated with a baby being born preterm versus being born at full term are significantly different. And so we calculate a cost of preterm birth being $57,000 in Tennessee per baby who's born. But we know nationwide there are billions of dollars spent to care for cost related to preterm birth, which may include the delivery in itself, any early intervention services that might be needed for a child who's born early, especially in that first year of life, and even lost productivity in the workplace. For parents who may not be able to return to work because they have a child with some special needs after being born premature, or maybe even having to take a lot of time away from the workplace in order to meet the needs of the family. So the March of Dimes, of course, is definitely concerned about these birth outcomes and work to encourage healthy pregnancies, to lower and eliminate some of these outcomes. And as I mentioned before, the health of the mom and baby is interconnected. You have healthy moms, you have healthy babies, is the goal that we're reaching for. In terms of preterm birth, just wanted to mention a few areas for possible solution. The state of Tennessee, I think, has some excellent things in place, again, that have helped us to move from a failing grade and a much higher percentage of babies being born preterm to where we are now. And so things like home visitation programs that seek to meet the needs of areas that may not have easiest access to healthcare. So a home visitor might be the only touch point that someone receives on a regular basis. The Nashville area, Angela's description of the Strong Babies Project definitely is another touch point, just a community level program that creates that network for moms and babies to be born healthier by sharing those resources in those networks. We also have the need to really address not only the health of the mom during pregnancy, but I always talk about the bookends of that. So the preconception health, are moms accessing healthcare services prior to her pregnancy? So am I the healthiest woman I can be in order to be the healthiest pregnant woman I can be. So addressing things like, kind of going back what Erin was saying, vitamin D intake, iron intake, but also things like folic acid intake, where women are taking in a multivitamin that could include all of those things, and specifically with folic acid to prevent birth defects of the brain and spine for the baby. But that intake only helps with birth defects prevention if a mom is taking that before she's pregnant. So I think the preconception health is important. Also addressing things like obesity, as Erin mentioned. Am I at a healthy weight now? Because during pregnancy, weight gain is typical. So really to be in that healthier space so that some of the things that could come from being overweight or obese are not a part of a healthy woman's scenario and would not be a part of her pregnancy situation, and possibly contributing to some of the outcomes that I know Dr. Ladson will talk about. But then the other bookend of that is the interconception piece. So I mentioned earlier, if a woman has a history of preterm birth, that can be a risk factor for another preterm birth. So what are those things that might not have been addressed in the first pregnancy that could be addressed between the next? And so, getting the same types of things under control, is, getting the weight under control, blood pressure, diabetes, healthy nutrition, fitness, incorporating all those kinds of things, seeing a doctor more regularly into that window as well. So all of those things can definitely play a role. I wanted to mention two other things that are going well in Tennessee, or opportunities, I would say, for possible improvements. And so things like group prenatal care, which I know Meharry has been heavily involved in. And for those who are not familiar, you have your traditional doctor's setting. And I know COVID-19 has presented some challenges around group prenatal care and healthcare in general. But you have your traditional setting where doctor sees patient, and it's just or nurse practitioner sees patient, just that one-on-one provider and patient. And then you have group prenatal care, which is where women who are along the same length of pregnancy meet as a group, and not only have responsibility for taking blood pressure and weight, but also get to meet as a group to get more education about things like healthy nutrition, or the importance of breastfeeding, or signs of preterm labor, whatever those things may be. And also develop a social network of women who can provide some social support. Sometimes hearing from a medical provider what you should do, what you can change, may come across a little bit differently than a peer from your community who might say, you might want to consider doing this, or, maybe more bluntly, you should stop doing that. You shouldn't be smoking. And so those groups create an opportunity to, for a woman to hear from peers in a different line of communication, so to speak. March of Dimes does have a group prenatal care program called Supportive Pregnancy Care that was actually piloted here in Tennessee. And so that's one model of group prenatal care that is available. I also want to touch on some of the social determinants of health, where they are contributors to poor outcomes for women and children. So things that I mentioned earlier, like poverty, or loss of jobs, violence in the community, create a level of stress that can impact outcomes as well. And so if a woman is, primarily concerned about a lot of those things, then some of the things that she needs to do for her health may take a back seat, unfortunately. And so we have to find some ways to address some of those things so that it's easier to access. I also wanted to mention that in terms of access, I always think of it in a couple of different ways. So it's not just that, does a woman have an insurance card? Does she have transportation to get to her medical provider or her medical home? Because that's addressing access in one capacity. But when she has all of those things in place and arrives at the facility where she's going to receive care, how is she treated? And so are there opportunities for implicit bias training for providers, whether that be the actual physician or nurse, or even the front desk scheduler, the person that's the welcome, to really address some of those things that become a barrier for women to access care, especially women of color. And some examples may be, when I come in and I have other children with me, is there some judgment that is attached to that? If I come in and I'm a little bit overweight, or if I'm obese, is there some judgment or treatment that's attached to that makes it difficult for me to want to access, with my transportation, with my insurance card, but I don't want to access that facility because there are implicit biases that are imparted upon me. And so I think that creates the opportunity for implicit bias training for us all to, really address how we feel, what are our own individual biases, and how do we counter that in terms of the care and the interactions with women, African-American women specifically for today, who need that care the most. And so those are just a few caveats related to preterm birth, and again, how the health of moms and babies are interconnected. And I'll just stop there because I know Dr. Ladson is going to talk much more about the maternal side of the mom piece.
Thank you so very much. That was very, very informative. And a couple of key things that I got from it is basically addressing those racial disparities. Obviously, there is an issue that we are, as Black women, we are dying from giving birth. So that is a fact. So it is so nice to know and to share the fact that we can do something about that. So with that being said, I am would like to introduce Dr. Ladson, MD, Professor, Chair, Director, Residency Program, Department of OBGYN. She's also the Chief of OB for Nashville General Hospital. She received her bachelor's degree, Bachelor's in Science and Biochemistry from Tennessee State University in 1980. Her medical degree from Meharry Medical College in 1984. She completed her residency training at Meharry in 1988. She was appointed as the residency program director in 2006. 2 years after that, she was reinstated of the department's residency program, and she was reappointed as a program director in 2018. I'm looking at her bio. She is members and accolades galore. We have really been blessed to have Dr. Ladson to be able to share with us on maternal maternity and mortality. So I'm gonna go ahead and turn it over to Dr. Ladson.
Good morning, good afternoon, everyone. And thank you for having me, allowing me to speak to you. And Tamara, you did wonderful. You guys, I've known some of you for a long time. And Angela, you're not supposed to tell me when I graduated from TSU, okay? Because someone's probably figured it out right now. It's like, anyway. But it is an excellent opportunity for me to speak. And not only because of what Tamara has said, what Aaron has said, and what Angela has said. One of the things that has happened in the state of Tennessee is, Tamara talked about infant mortality and infant prematurity. And so for the longest, everybody talked about the baby and the baby being born full term and surviving to the 1 year age. And we don't think about when you're having a pregnancy and having a baby, no one says, do you know your baby may not live to be 1? You don't even think about that. No mother is thinking that their child may not live. So I applaud the March of Dimes on all their outcomes on decreasing infant mortality and prematurity. However, as she said, it takes a healthy mom to have a healthy baby. And so there's a lot of things that happens. So the state of Tennessee joined the Maternal Mortality Review Committee across the country. We were the 48th state, I think, out of the 50 states to develop a maternal mortality review committee. As Erin said, the review committee looks at the causes of death related to pregnancy within 6 weeks of having a baby, up to 1 year. 1 year is 6 weeks. Depending on, it doesn't matter what the cause is. It could be pregnancy related, pregnancy unrelated, but the patient was pregnant, had a positive pregnancy test. And it took a long time for the legislature of Tennessee to do that because you had to have a death certificate. Most of the time in most states, a woman died and she may have been pregnant, but no one did it cause of death. They just said she was pregnant and she died. And so there were no records kept. And other countries had maternal mortality review committees. Other states had it, but Tennessee was slow and it took a long time, but they were concerned that they didn't have the people to look at the data. So the data is now being looked at, and that review committee is occurring. And we do know that there are people who die from pregnancy-related causes. And so most of the time you think about it, and if you ask my residents, well, what's number one cause, they may say preeclampsia or eclampsia or toxemia, common term toxemia. But it's not toxemia, it's related to heart disease. And so we think about death of heart disease from anybody dying. It's the number one cause of death in the country. The number one cause is not cancer, it's not breast cancer, it's not cervical cancer. We talked about all those things, but it's heart disease. It's the number one cause of death of any cause. But right now, because of the pandemic, it's becoming the number two cause of death in the country. And pretty soon it's going to be the number one, that is COVID-19. So I say that to say we have to vote and we have to get this pandemic under control. So when you think about maternal causes of maternal mortality, it is in Tennessee. I'm going to go to Tennessee. Tennessee the committee looked at the causes of death and looked at the data in the last, since 2017, they looked at the data. And the data is not placing blame on any physician or any provider or any hospital. They're just looking at the data. And so the number one cause in Tennessee is related to, is tied between sepsis, which is a cause, it's an infection throughout the body, or eclampsia. I'm sorry, sepsis and DVT, so blood clots. So and there's a third one that's causing is cardiac disease. So when we think about women who have died from a heart disease, you don't think that they have heart condition. They didn't know it, but they may have had a cardiac condition that was not recognized. And sometimes if you think about your grandmothers or your great grandmothers or whoever said, well, she's swelling, taking too much fluid, she's too swollen. And everybody says, well, after you have the baby, your swelling is supposed to go down in about 3 days, and your feet is the last thing to go down. But the women are being discharged from hospitals with a lot of fluid and swelling around their heart, so they have pulmonary edema. But they also get pulmonary cardiomyopathy. Cardiomyopathy is where the ejection fraction, where the heart is pumping, and it cannot pump. It's weakened, and it cannot pump the blood throughout the body. And so then it becomes that blood doesn't. So the woman complains of shortness of breath, and they're still swelling. That fluid is just not getting passed out. And they may go into pulmonary edema, and then they may go into pulmonary edema in the lungs, throughout the body, and they may die because the heart is too weakened to pump the blood throughout the body. And you have to have a strong heart muscle to pump the blood. And so the way you recognize a cardiomyopathy is you have to have an echocardiogram. And that's a special ultrasound of the heart, looking at the heart vessels. and it measures the pumping of the blood throughout the heart, and it's very weak in someone who has heart failure. So heart failure is, we think about that in older people in the 70s, 60s, 70s, 80s, but this is pregnant women who's having heart failure because of cardiomyopathy. And if a woman has postpartum cardiomyopathy and they come back, it has a very high mortality rate, almost about, it depends on the ejection fraction on how weak the heart is, and they may die a 50% death rate from cardiomyopathy. So one of the things that we have to get approved by insurance companies is that a echocardiogram of the heart. And the thing about having that approved by insurance company is that they say, well, the people who do that are cardiologists. And so most cardiologists say, well, she's pregnant, so this is not part of your insurance packet. She's just, you want to get that postpartum echocardiogram within, a certain day, but you have to fight for it. You even sometimes have to fight the cardiologist to actually do the echo. And they say, well, just give her some laces, that'll get the fluid off and she'll be fine. Or they're not comfortable looking at an echocardiogram at a heart on a pregnant woman, because one of the things that happens with pregnancy is that your heart muscle enlarges, but it should not enlarge but a certain amount. It is a muscle, but it should not be weakened. We think about pregnant women, they're short of breath and they're tired, and they say, oh, you're just at the end of pregnancy, this is going to get better. And so we cannot dismiss that. So if you have family members and their family members or friends and their children are pregnant and they're having shortness of breath and they're swelling, it's not just because the baby's pushing up into the lungs and pushing and shortening the lungs. There's a smaller space for the breathing. And so it could be the heart. So you want to not dismiss that. So other thing, as far as some of the sepsis is when you have an infection throughout the body, and that is associated with tachycardia, rapid heart rate, fever, and infection. It's an infection throughout the body. So one of the things that happens with this infection is that if it's not recognized and captured right away, then you get behind, as we say, get behind the 8 ball. And if you don't start the antibiotics, the high dose antibiotics, and the mother goes home and nobody recognizes that she's got this fever, they say, oh, she's just got a fever, or she's just tired, she just had the baby. Someone needs to, when you call back to the office or call back to the language line, or what is the language line, or it's the nurses that you call back to, and you said, I'm having this, I'm still not feeling good, and you may have to go back in. So you got to have an advocate, whether it's a family member or a relative, to advocate for that patient, because someone may not give you they may not take you seriously, or they may think that you just had the baby and you're still tired, you're just tired. Don't let that, you want to recognize and get on that right away. So that's the sepsis. The DVT from a blood clot. A blood clot is when you have when you're pregnant, your heart, your body produces about 3 times the amount of blood that you normally have. And so you have to do something with that blood. And your body makes estrogen. Your estrogen increases like 3,000 times when you're pregnant. And that's to grow the baby. So the progesterone levels also rises as well. And so once you have the baby, those estrogen levels come back down. But because of that high estrogen levels, estrogen is associated with increase in blood clots. So you have to have the fibrinogen levels that go really high so that it can stop the bleeding when you have the baby. And so if it doesn't stop the bleeding, then you have something called postpartum hemorrhage. And postpartum hemorrhage, if you think about a hemorrhage, and what I'm holding a bottle of water, and this is about 500 milliliters. So when you have postpartum hemorrhage and the uterus does not contract after you have the baby and deliver the placenta, about every minute you lose one of these every minute. And so the fibrinogen level, which causes the blood to clot, the reason that level is very high, so it can make the uterus, the body, to make the fibrinogen to stop the bleeding. And if you don't have enough of that, then you will continue to bleed. So one of the things that you have to recognize that we are doing more, and that's just not with Tennessee, that's nationwide. Looking at cause with maternal hemorrhage, postpartum hemorrhage, having the staff, whether it's the providers, the nurses, anybody who's working with pregnant women, recognizing that how much blood should be lost at delivery and getting on that right away. So if you've had a baby and you just have a small amount of blood that's lost, because most of the time we unmeasure. We always say, how much estimated blood did you lose? And you may say a cup. We don't say a cup. We may say 100 cc's. 100 milliliters is just a small amount that you should have a whole week when you have your menstrual period, for a whole week. So most women and most physicians and most providers and most nurses underestimate how much blood is lost. And so one of the things that does happen is that blood is lost. And if we don't recognize it and start acting on it by adding either more medicine, whether it's Pitocin, more uterine fundal massage, or if you need to have other a cytotec, which is put in the rectum, or oral medicine to keep the uterus contracted, then the bleeding will continue to bleed, and you will lose more blood. So the things that we talked about was postpartum hemorrhage, and with that large amount of blood loss, and if you're doing this much blood that you're losing every minute after you have a baby, it's very hard to catch up. You'll get behind. And so then after a certain amount of blood that's lost, I mean, you're basically going into the rapid response team, blood team, like you're at a car accident. So because that much amount of blood is coming out through the vagina every minute, this much blood is being lost every minute, then you may not catch up on it. And then the next thing you know, the woman may go into what we call DIC. And so her blood, she can't catch up with her platelets and her clotting. And so then she goes into the next DIC, then she starts bleeding out of her eyes and her lips, and you can't stop the bleeding. So that is a very serious condition. And I know you may have seen on the news a couple of years ago where the patient in California at Cedars-Sinai, and her husband is presented throughout the country because she went in for a routine cesarean section and she started having a hemorrhage, but they didn't recognize that she was hemorrhaging. So as was stated earlier in the first part of the introduction, is that her mother recognized that she was in a lot of pain. And so when you're talking about, and this patient did everything correct, but she was bleeding internally. And by the time they believed her, when her mother said she's bleeding outside of her vein and outside her incision from her C-section. And then they finally got her to the operating room, and she had so much blood they couldn't catch her up and they couldn't get her back. So that's one of the things when we're talking about implicit bias or implicit bias, because they basically thought she just wanted pain medicine. And she did not just want pain medicine. So I think I went kind of fast on preeclampsia. Eclampsia is when you have seizures. So preeclampsia, and it's an old term, is toxemia. That's a common term. So toxemia, there are a lot of women who, and the blood pressure is 130/90. You don't want your diastolic, the lower number, to be above 90. And so the American College of OBGYN, when you have a preeclampsia, there are labs that we could do, and there's other labs with the urine, and you also may spill a certain amount of protein in your urine. And you want to, if your term is to have a baby, to be delivered, you don't want the blood pressure to go continually higher and higher. And then you're at risk for having eclampsia, which is a seizure or a stroke or a coma for eclampsia. So there are a lot of African-American women going all the way back. I think one of the things that I remember as a teenager, one of my oldest sisters down in a small town in Georgia, her classmate in I think she was in the 10th grade, had a baby, and she died of an eclamptic seizure. And they just said she died. And so women have died from eclamptic seizure. As Tamara says, preconception planning. If you're planning on becoming pregnant, there's certain things you have to do or try to be healthy for. The vitamin D is good. The folate is absolutely important. And we can get folate in our bread. And, nobody wants to eat bread anymore. But unless we grow folate, we're probably deficient. And because our skin has more melanin, as Erin says, our vitamin D levels are low. And I think I just read a study that's been looked at out of New York, I believe, on individuals who have corona have lower vitamin D levels, and they think it's because of that they have a higher levels of complications. So there's a lot of things besides vitamin D, but diabetes, all of those things are related to that. I think Tamara was correct in terms of social determinants of health. And we have women who can't, and I've heard not only in clinics, and I heard in the hospitals, our hospital, another hospital had privileges, and they said, oh, she's coming back with another baby. And so not that is their business, but this is, so they're already in their mind say, here she is, and they're using our TennCare, our taxpayer money. So they're being mistreated, and that's what's happening. The centering group prenatal and supported pregnancy, those things are very, very important. No matter if someone is their third baby, fourth baby, sometimes this is what they're learning. So with the supported pregnancy, with the Nashville Strong Baby centering, not only do we have the women who empower them to know about their body, but also know about, you don't have to be induced. You can go to term. You don't have to be induced early to try to decrease your rate of cesarean section. And one of the things with the group prenatal is that the inductions were lower. And we also had a very high breastfeeding rate. And so breastfeeding, and that's another issue where we need to increase the number of African-American women who breastfeed. And so I don't mean to try to throw anybody under the bus, but I said, there's another person there with the family. I said, well, do you want to give your baby cow's milk? Your baby's not a cow. And they say, Dr. Latson, I said, just try it. And so then I had to tell them the story, because when I had my first child, it was hard. And the nurse said, she just said, well, just try it and call me back in 3 days. If it don't work, then you can stop. And I said, I'm going to do this, but no one is helping. But she didn't come to help me. She just said, just try it. Just try it. So that's what I think we have. We have people who are not comfortable to help people to breastfeed. So that's another thing that we can improve upon. Let's see. Can you think of anything else that I may have missed, Angela? I'm sure I did.
I'm sorry. I think you covered a lot, Dr. Latson. Can you touch on, I know you mentioned it probably not on this call, but before, about substance abuse briefly?
Okay, so one of the things with substance abuse in pregnancy in Tennessee, I'll just do Tennessee. So Tennessee it's not like the Northeast where there's large opiates and everybody's ODing, but it does happen in Tennessee, and it's going higher. And what we do know is that the substance abuse in African-American women is not as high as in Caucasian women, as well as smoking. We have a lower rate of smoking in African-American women, and if they do smoke, they will stop. And then they usually start back afterwards. But there's a higher rate in East Tennessee, and also there's higher rates of the heroin in East Tennessee. But Nashville is its city, so people moving here, so they're bringing some of the other stuff here with them, meaning they have access to it. And what we are seeing, I'm hearing more people, they're not pregnant, but they're their siblings or children are overdosing on the opiates, which is really bad. And but the thing that happens with the opiates is that now it's a health disorder, it's a medical condition, and so you can go and get treatment, and we can help you instead of putting you in jail. So that is what is happening nationwide. And so one of the things that we do have at Meharry, we have a contract with the Tennessee Prison for Women. And, you know, it's unfortunate that there are more women who are incarcerated, and it's usually related to drugs and opiates, and they get busted. And so, but they're pregnant. So the judge says, you're going to jail. I mean, you're going to prison. Jail is just up to 6 weeks, but prison is going to the big house. But we see them and we deliver them here. And it's really kind of sad. But sometimes when they're in prison, unfortunately, they do get the meals, and the babies, the biggest babies they've ever had, and they're growing, they're feeding, blah, blah, blah. And they do want to breastfeed. Okay, but what we see is that if they're coming from East Tennessee, they're mostly on the opiates, but that's the Caucasian, more Caucasian. West Tennessee is not. They're usually related to being busted for some reason.
Awesome. Thank you, Dr. Lancet.
You're welcome.
A lot of information. At this time, I'm gonna turn it back over. But before I do, I just want to make another point before we go to the Q&A. Is the importance of addressing stress in pregnancy. I know it hasn't been mentioned yet, but I know that, I call it a Black woman syndrome. I mean, we take on a lot, and pregnancy is just another added to our already long list of things we have to deal with. So definitely, if you're stressing, that's something that can affect your baby in your pregnancy. So definitely want to address that. Okay, so I'll turn it back over.
I think I want to just say one thing about that. There's a researcher out of LA, and he's looking at the stressors that has affected African American women going all the way back to slavery. And so when we talk about preterm, and he's looking at the data on preterm birth related to the genetic changes in African American women and because of slavery. And so one of the things that he looked at is that you cannot be, just because they don't have enough progesterone and they don't have enough this, it's in the genes have been mutated, he thought, because of slavery.
Interesting. All right, well, I'm gonna turn it back over to Scarritt Business Center for the Q&A. Thank you again, everybody.
You're welcome.
Wow, what great information. Dr. Ladson, what I really want to do is invite you over to my house and bring some of my girlfriends, and we just kick it so that you can really just, the wealth of information that all of you shared, not just Dr. Ladson, is my camera was off and I was really getting emotional because as a Black woman, I feel seen and heard with the information that the four of you provided. So thank you all again so much. We do have some questions that I want to engage you all, and any one of you can respond to these questions. The first question is, could the use of different types of birth control prior to pregnancy have an effect on healthy pregnancy, such as IUDs and depot? Could the use of different types of birth control prior to pregnancy have an effect on healthy pregnancy, such as IUDs and depot?
I can speak on it a little bit. So in terms of IUDs, there's not as much research about it just because they are kind of a newer thing. Depot, I try to educate my patients about depot. One of the big side effects of depot is your return to fertility. So within 10 months, about 50% of women will get their fertility back, but it can take as long as 18 months for some women to get their fertility back after being on depot. So if there's a patient and she wants to go on birth control, but she wants to be pregnant in a year, depot wouldn't be the best option for her. The pill, I mean, there is more research on the pill since it's just been around for longer. It has been associated with some nutrient depletion, so micronutrient depletion, such as B vitamins and folate, selenium, zinc. So I think it would be pertinent to check your micronutrients. I personally did before I got pregnant to make sure that those things were all in line before I got pregnant to have the healthiest pregnancy possible. There also can be post-pill amenorrhea with taking the pill. So some women, they are on the pill, they get off the pill, they have a period right away, the fertility comes back right away. For other women, it can take a while as well, kind of like Depo. Depo is definitely more notorious for that, I would say. But there are cases where women have been on the pill for like 5-10 years and then they get off of it and they don't have a period. And it can be harder for their fertility to return. Again, I think the things most pertinent for this question would just be, again, if you're on the pill, to test your micronutrients, make sure you're having a very micronutrient dense, rich diet. So green leafy vegetables and meats and liver. Most people don't eat liver, but it's extremely nutrient dense. You can put it into other foods, hide it in other foods so you don't really taste it as much. So like you could put a little bit of liver in your ground beef and you don't taste it and you're getting all the benefits that liver has to offer. Folate, again, that's a big one. And a lot of people also have a genetic variant called MTHFR. If you have that genetic variant, up to 60% of people have a deficiency or aren't able to absorb folic acid. Either they're not as well or not at all. So folate is really the preferred form, not folic acid. Folic acid tends to be in cheaper prenatal vitamins. So the more expensive good prenatals tend to have folate, the active form of folate. And then also, again, getting it in from your liver, green leafy vegetables would be most pertinent.
So I asked a question about the IUD. So IUD does not affect anybody who wants to get pregnant. They just have to know they want to have an IUD. If they have an IUD, it won't stop them from getting pregnant. IUD has been associated with infections, but Dalcon Shield is no longer on the market. If you have an IUD and you want to get pregnant, you want to make sure that, again, just get preconception, physical, etc. And so it makes sure you don't have any STIs. So the other thing is that as far as foods, and some of the places where our patients live, there may be 10 churches on one street, but there's no grocery stores. There's no place they can go get fresh liver. Because liver is, you got to go still get liver, but you also have to go get some vegetables and you have to go make sure they have it. If I go right down from Meharry, I can walk to 3 Dollar Generals, Family Dollar. They don't have Dollar General in this neighborhood because it's not the right neighborhood. You now Dollar General is in Brentwood, okay? So it's in the gentrified neighborhoods. So we may get one later. But if you go in there and they could take their card and the family, for that one card for their food that has to last for a whole month, everything is canned. There's no fresh anything. It may be a couple of bananas, but they go bad. It may be a couple of apples, but not usually. But everything is canned. So you're exposed to, they may want to do right, but you can't, they just cannot get, it's a desert, what they call a food desert.
I agree. And the system is broken. And, people who are on food stamps, which is a huge industry, you're limited also to whatever food stamps provide. And I think
they don't call it food stamps anymore.
Well, it's the SNAP program, supplemental nutrition.
Yeah, I know. I'm just messing with you.
But people associate with that. I mean, and so it's really broken. And like, I think 75% of SNAP funds go toward like junk food and soda. So it really is like a broken system. And you can't even with SNAP, you can buy soda, but you can't buy rotisserie chicken because you're not allowed to buy any cooked food. So it's kind of a broken system too.
One of the things is that, I've seen and not seen, but I see, in the waiting rooms, the mothers have their babies and they got strawberry milk, because that's what they buy in the places. So, and so you wonder why the children are obese, because that's what they're getting. So they're not breast milk, but it's strawberry milk.
Yeah.
I know.
I just wanted to add, as Dr. Watson said, I'm sorry. I
No,
just want to add real quickly, as Dr. Latson said, the importance of that pre-pregnancy or preconception health visit, women seeing a physician before they're ever pregnant. And I just think it echoes the, pre-pregnancy planning, not only to discuss the birth control that you're on, how much time it would take, but to be able to incorporate all those other things that need to be put in place for a healthy pregnancy. And then just one caveat, I believe with some of the WIC offerings now, you can purchase fresh fruits and vegetables, if I'm not mistaken now. So that's another added benefit and resource that the community could access for healthier pregnancies and healthier babies.
Dr. Latson, can you address the issue of women who have abnormal bleeding because of fibroids, and just the various different, and Black women suffer from that significantly. So could you speak to that specifically for Black women who would like to have children but suffer from imbalanced bleeding?
So thank you. That's a good question. So when you think about, let's go to fibroid. Uterine fibroids are tumors, which are benign tumors. They're not malignant. There's very, very rarely that they can become malignant. However, 98% of African-American women have uterine myomas or uterine fibroids or leiomyomas. And they may range in size from a peanut to a softball or a baseball. And it depends on where the fibroid is located. If it's inside the cavity of the lining of the uterus that blocks the baby's passageway through the canal, then it may cause problems. It may affect pregnancy. It may affect the inability to get pregnant. So also the leiomyomas respond to estrogen. And as I stated earlier, estrogen is what grows 3,000 times when this pregnancy happens. So it can grow from the placenta and the ovary, so the baby can grow. So the fibroid and the placenta are competing. The fibroid and the baby competing with the placenta for blood flow. So normally we don't have to take a uterine fibroid out when someone's pregnant, or they think they may take it out because they may miscarry. Unless it's been shown that it causes the miscarriage, you leave a fibroid in there. So in terms of abnormal, because once you go into the endometrial cavity and you open it, go into the uterus and open, and then you go into the lining of the uterus, then you're required to have cesarean section. That part of the myometrium, which is the muscle of the uterus, a higher level does not contract. And so if you go into labor, it may increase your risk of a uterine rupture. So you want to leave the fibroid alone if you don't have to take it out. If someone has a cesarean section, it is down at the level of the cervical area, that does not contract when you're in labor. So therefore they can have a trial of labor after cesarean. Abnormal bleeding, uterine bleeding. So there's different causes of abnormal bleeding, where there's polyps, fibroids, estrogen and progesterone deficiency, imbalance. So sometimes, as Aaron stated, when someone has been on Depo-Provera, it may take up to a year before their hormonal balance becomes normal again. And so until that hormone is in balance, estrogen progesterone level is balanced, then they may have irregular bleeding. Depends on the age of the woman. It depends on how you manage the bleeding.
Thank you.
I mean, that's a one day at your house discussion.
Yeah.
Okay.
So we're still in the midst of a pandemic. I know many people are not wanting to believe that or acknowledge that. So here's a question from a viewer. How is COVID-19 impacting prenatal care and the birthing experience in Nashville? For example, is there anything a pregnant woman should take into consideration when she is in public, given people in the general community might have COVID-19? Are husbands, partners being allowed in the labor and delivery room, etc.? Come on and tell us about this mask now.
It's right here. I mean, not only masks, you know, Dr. Hilter's been on television quite a bit, and he's talked about the T zone. And not only can the virus get into your, it's in the air, but it's also when you rub, it can get into your eye. So you got to be careful about wherever you are, and everything's got, wash your hands, wash everything down. And, you know, everybody's tired of wiping and washing and cleaning, but you have to do that because otherwise, you know, I think I got sanitizers everywhere I go, but, you know, making sure that whatever you touch, you know, someone just came into my office and she's spraying my door because I had 3 people in my office, which, you know, we spaced out, but it is serious. So I think as far as pregnant women is concerned, there has not been, I think it was London where they recognized a corona in the placenta, but that's not been repeated nowhere in the US. And so if a mother has corona virus, test positive, because we are in our hospital, we tested all the pregnant women. Now anybody come into L&D, we're testing them. Everybody's getting the rapid test. And then if they have other symptoms, and then we would do the other swab. But so you want to have all of your family members. And then we also, at our hospital, then you have a person, they come, and then they have to stay there the whole time. If you're going to be induced, then they got to stay there. They don't want them to go in and out, in and out. That would be your support person for that delivery. The other hospitals are doing the same thing. When it was really, really bad back in March and April, then they had pretty much nobody, but they stopped. We fought for someone to have a support person with them in L&D. If a person has a positive COVID and they're pregnant, there are certain times of the pregnancy where it becomes more serious. And if they're symptomatic and it's in their lungs, and they may increase their risk of cesarean section. And then it depends on how far they are in the 3rd trimester, if they're having bleeding, diarrhea, any other things, their O2 sats is dropping, those kind of things. So if they have other pre-existing conditions like diabetes, those kind of things put them at risk for more complications of the COVID.
Another question, and again, any one of you can answer this. How can Black women, this is from a viewer, I recently lost my god sister who passed during childbirth. I'd had several pregnant friends reach out about their anxiety. What's the best way they should advocate for themselves? And also, what would you say, or what can you say to Black women who are pregnant and they hear the statistics of Black women dying, whether in childbirth or even after? I mean, the information that you all shared today about the various different things that we should be considering. What would you offer to women who are pregnant, who are watching today? 1, for their anxiety, but 2, also, how can they advocate for themselves?
I would say, you know, women, you know, make sure to consider yourself your own best advocate. I mean, you know your body, you know what's going on, and just being open and vocal about whatever is being experienced. Sometimes it can be kind of a difficult place to communicate with a physician who has a whole lot of knowledge. I mean, everyone, unfortunately, isn't going to have someone like Dr. Ladson. But really having that, you know, taking that authority that this is my body, this is my baby. I am, you know, the voice for whatever is happening here. I'm having this concern. I'm bringing it to the table. I really feel like instinctively something is not right, and not having those things dismissed. You know, we have the, you know, old, you know, bias of, you know, for African-American women specifically, you know, they can endure more pain, or the concern is not real. So really just really trying to find a way to balance that as being your own advocate. And then for some women, you need someone to be there with you, to help support in advocating and bringing those concerns to the table, especially during labor and delivery. We talk a lot of, you know, these days about doulas. Being with a woman to provide that added level of comfort and support and navigation through the healthcare system. So, you know, don't stop, you know, speaking up. I mean, it's a very simple recommendation. Sometimes it's easier said than done, because there are a lot of other factors in play. But a woman, has every right in her healthcare setting to speak up and ask for her needs to be met and her concerns to be heard.
Yeah.
And,
Tamara,
and most hospitals have a patient advocate, so you can ask for the advocate
yeah.
as well.
I want to sit here for just a little bit. I served as a chaplain at a hospital in Georgia, and one of my units was the pregnancy and delivery unit. And one of my patients was a 16-year-old Black girl who had no one with her in the hospital room. And I noticed immediately how she was treated differently. I also noticed how Black single women were treated very differently. And so I want to sit right here, and if you all can share a little bit more about, particularly for the women, again, who are pregnant, why it's important to have community. What is a doula? You mentioned, Tamara, doulas. For those who might not know what a doula is, could you talk a little bit more about what doulas are, the resources of doulas? And again, Dr. Latson, you talked about the patient advocacy. This is for the 16-year-old little girl who's pregnant, and unfortunately, she does not have the support. But when she goes to that hospital room, she needs it. So could you share a little bit more resources for the Black women, the Black girls who are watching, about the resources that are available and why it's necessary to have community while you're in such a vulnerable state?
So one of the
I
things
have something to say to that too, real quick, Dr. Latson. But I think all through the different presentations, the one thing that kept jumping out in my mind is it takes a village. No one should ever have to go through anything by themselves, and I think that's one of the neat things about group care is that, you're around other people who are going through the same thing you're going through. So you have a venue to talk about concerns that people can relate to. So that's why I'm very much an advocate of group care, because, it's scary doing it by yourself and being in an environment that people don't really understand. I mean, if you're pregnant and no one else around you pregnant, you just deal with it, and that's the message you get, deal with it. And a couple of things I wrote down is, if you think you're pregnant or you think about getting pregnant, talk to your doctor. If you think you're pregnant, talk to your doctor. If you can't talk to your doctor, get you a new doctor. It's really, really important to be able to be comfortable with your physician and your primary physician. And I think it's really, really important to, again, being able to have that network of support. That's what I got.
And I'm going to say too, I mean, just in terms of like advocating for yourself, I think I totally agree with what everyone has said, and the importance of community in terms of advocating for yourself and finding a doctor or a provider who's going to work with you. Like your provider can know everything and be an expert in everything, but if they're not willing to have shared decision-making with you, then they're not the right fit. Someone who's talking with you and not at you. That's extremely important. Community, I can definitely say community while I was pregnant. Afterward, postpartum is a really hard period. It can be a very isolating period for a lot of women. And luckily I had resources. I had a postpartum group that I met with at the birth center where I gave birth, and we met every few weeks, which was great. Breastfeeding is extremely difficult. I don't think I fully realized it before I had a baby, before I started breastfeeding. And that's why, I tell my patients too, when they want to breastfeed, great. And there's so many benefits to it. But support is key for breastfeeding too, because those first couple weeks are really hard. And if you don't have a partner or a family member or support to help you, it makes it really, really difficult. And Nashville, shout out to Nashville Strong Babies, the program. I think that's going to be a really good resource for women to have community and to talk with other women about what they're going through and make it not as isolating, and just make them realize they're not what they're experiencing. They're not the only ones experiencing it. They're other pregnant women who are going through the same thing that they are.
And I mean, it's such a
Tamara,
hard.
would you say a little bit more about doulas and the doula services? There are several of your colleagues who are posting with enrolled, someone says enrolled Nashville Strong Babies moms have access to doula services completely complimentary, worth more than $500. Talk a little bit about what a doula is and the services that's provided for those who might not have, insurance or the various different, privileges that other women have.
Absolutely. A doula, and I'm, don't have the technical definition, but you have your medical providers, whether it be an OB or a nurse practitioner, a midwife, but you also have doulas who are trained professionals, not necessarily considered medical providers, but definitely provide that support that a woman may need in navigating through some of those difficult situations. Dr. Latson alluded to some things where Meharry may have certain privileges or patient navigator available, other hospitals, may or may not. So every setup in a delivery situation is going to be different. And so a doula is just an added piece for a woman, just that extension or a liaison between some of the medical conversation and what the woman needs, even feeding some information that might be important because they've seen other situations before, encouraging a woman to ask a question or express a need, but, continuing that encouragement or actually stepping in to help assist in getting that question answered or that need met. So doulas are definitely one major solution to some of that navigating the healthcare system and that experience for delivery and childbirth. And I think, it's a difficult scenario. There's not just one solution. Doula care is one piece. We've mentioned several times about the implicit bias. And so kind of being not only pregnant and trying to navigate your health and the baby's health, that lane alone is big. But then if you have all of the other things coming at you, whatever stressors might be at home, your medical situation is not ideal, you're not being heard, it becomes a bit much to navigate. And so having that added support, if you, don't have family that can be with you, like the 16-year-old that you described, or a patient navigator at the hospital, doula care can assist in those ways. And it is a key component of the Nashville Strong Babies project that is essential, I feel like, for the women who are targeted in those zip codes.
And I think one of the things I know one of the things that has been approved through the hospitals that this other supportive person can be the doula. Instead of the doula and another father of the baby or mother of the baby, grandmother, so they can be there as well and be part of the team, because because of the corona, they're not allowing anybody in, but they're allowing the doula in as a second person.
Yeah.
And so one of the things that happens with the doulas is very good. There are different types of doulas, and some will charge you more than the charge of a prenatal visit or the delivery. So those are the people who have the money to afford that type of doulas. That's probably the prince and princesses. They can have that type of doula. And they come to every prenatal visit, and they're taking notes and videos and taking the whole diary of the pregnancy, the whole works, delivering everything. But sometimes those type of doulas are not accepted as much. But we don't have those kind anyway. We want the kind who can really help the patient and help the family. And then they'll be good for the nurses, so there won't be any issues where you get any conflict between the medical staff and the doula and the mom. So sometimes the young people, they look at the baby story and they think that the baby's going to be delivered within the end of the next commercial. And now she's 8 centimeters, now she's going to have the baby. And they realize that it doesn't happen that way. And that was one of the good things about group prenatal. The childbirth class, they learn about what childbirth classes, the Lamaze, what actually happens. So that was really good. And do the tour of the hospital. And I think that we're trying to do is have the L&D nurses do childbirth classes so they get to know someone who is an L&D nurse. That's the best thing that could happen as well.
Yeah. I'm looking at the time.
Mm.
I mean, I really want to just invite y'all over so we can continue this conversation. There's just so much great information. And I really do hope that our audience members are paying attention and would replay this video because valuable information was shared today. And I hope you all, I want to invite our audience to share this post. Please put this on your Facebook page, share it, tag sisters who need to hear this information. This literally can save a sister's life. So as we close out, I want to invite you all to offer closing remarks as we leave this space. And let me start with you, Erin.
Okay, closing remarks. So I would just say, like we've said before, pregnancy, before you get pregnant, I would just ensure that you're in the best health, because in order to have a successful pregnancy, successful birth, postpartum period, being in the best health possible before going into that is really key. Making sure that you are working with doctors, nurse practitioners, healthcare team members who value you as a person and value your opinion and are allowed to challenge you. I think that's all really great. And yeah, and take your vitamin D. It's really important.
Thank you, Erin.
They're calling me from the hospital. Anyway,
Dr. Larson, before you go, would you offer closing remarks?
Oh yeah. 1 second. I'm just saying, let me call you right back. Okay. I just called. Hope it's okay. This has been a great show. I really enjoyed it, and I've been seeing this virtual Zoom things all on MSNBC, and I say, we could go on that, but I gotta make sure I look okay. But that's all right. But it is so important. I just want to reminded me of a patient from a couple of years ago. Her OBGYN died, and she said, Dr. Latson, he never looked up at me the whole time. She said, this is the only visit with someone that's actually listened to me. I said, you kidding? He never had looked at, he delivered like 5 of her kids. He never. And I said, oh my God. So one of the things that I want to do and impart upon the students and the residents is that you have to listen to your patients, and you have to have bedside manners. So one of the things that happened, basically she said, he just does this thing on the computer, did nothing else. I know it's electronic records, I know it's this, but you got to listen to the patients. They didn't know their patient. So sometimes you ask people, who delivered you? I don't know. It was just in and out. So that's not how I want to be. So listen to your instinct. Listen to your gut. If you think that something is not right, listen to that and bring it up. Ask somebody else. If it's not right, ask somebody. Don't sit there and suffer. Thank you.
Thank you so much, Dr. Latson, for your leadership and your mentorship. Because let me tell you, I have been in the doctor's office and been the patient where my doctor did not look up at me. And I keep reiterating that because I think sometimes when we talk about our experiences, people don't believe us. But absolutely, I have been that patient where the doctor did not look at me. So thank you, Dr. Latson, for your work, your passion,
my pleasure.
your leadership. Tamara, if you would share your closing remarks.
Absolutely. It's been a pleasure just having the discussion today, and always learning from those who are having direct interaction with the patient and delivery and childbirth. So pleasure to be here with Erin and Dr. Latson and Angela. From the March of Dimes perspective, I think our mission, as I mentioned earlier, is to, fight for the health of all moms and babies, aiming for stronger babies, healthier moms, and really trying to bridge that gap and make that connection between the mom's health and the baby's health, and, bridging the maternal mortality outcomes and the infant outcomes as well. And so just keeping in mind, I think we've talked about a lot of different things. There is not one solution to this problem around maternal health outcomes. And there are a lot of different things that can be done across the country, across our state, and that may look a little different in terms of the needs in those 95 counties across the state. You know, what works here in Nashville to improve may not be the same solution for Memphis. So just really keeping that in mind. But some of the key things that are brought up, I think that are tried and true recommendations across the country include, you know, group prenatal care, really building in that supportive network within those other pregnant women within those groups. Also, doula care, you know, the implicit bias training, and all of those things, and even those pieces that tell us what the problems and what the needs are. So our perinatal quality collaboratives, our maternal mortality review, all of those things that really give us the benchmark for what we need to do and where we need to go. So just really appreciate this important conversation. You know, again, multifaceted solutions. So really just pinpointing what we can do in our individual organizations and what you can do, those who are listening on the call as individuals, to try to move things forward. And if you're interested in advocating for policy with March of Dimes, feel free to look up our action network. And as legislative opportunities come about, federally and in the state that improve these outcomes, you can be alerted of how you can lend your voice to those causes.
Really quickly, Tamara, if you would give us information about March of Dimes, the website, the contact number, we would love to put that on our comment sections for our audience.
Absolutely. You can go to marchofdimes.org. And it's pretty easy to navigate there. You can find the report card that's listed there with some of the policy recommendations that I've mentioned, those multifaceted things, but marchofdimes.org is the place to go. And then you can reach my desk at 615-800-7181.
Thank you. Thank you so much for being here and for sharing such great information with us. And last but certainly not least, our moderator today, Angela, if you would share your closing remarks as we leave this space.
Sure. Thank you again so very much for this platform to be able to speak on this topic. And just to close up again, just want to put that out there. It takes a village, and I would like to also put it out there. Meharry will love to be a part of your village. So definitely, please. I think my name and my contact information will be shared. So please, if you know someone that's pregnant, looking for a provider, or just need that extra support in their pregnancy, please share the information about Nashville Strong Babies program. Even if they with another provider, I'm sure we can make sure they are taken care of. Okay. Thank you again, everyone, for your time.
Awesome. I want to thank each of you. I mean, you all have convinced me. I'm looking at my insurance now to say how I'm going to, I need to transfer my healthcare provider over to Meharry because y'all got some magic going on that I need.
All right.
Thank you all so much for joining us this
You're welcome.
And for sharing such great information. Again, to our audience members, let me encourage you to go ahead and share this post on your Facebook page, tag some Black women so that we might together possibly save some lives with this information here. Many blessings to you. God bless you. Bye-bye.
Bye-bye. Bye, everybody.